Right, so thanks for watching. This is a quick video to explain the new OpenTrials.net project, which I'm building with the Open Knowledge Foundation, funding from Laura and John Arnold Foundation, and some back-end hopefully from Centre for Open Science. So this is a fireside chat. Do not expect a polished video. I'm going to walk you through some slides and some screenshots. Hopefully you all know about the problem of trials going missing in action. This is what we started the All Trials campaign for, and we ask for all trials to be registered with their methods and results fully reported and in the public domain. But there is a bigger problem, which is that the information architecture, if you like, of evidence-based medicine is a kind of flawed, inconsistent mess of old legacy systems with very little joined up data. So the Open Trials database is a structured, linked, threaded, freely accessible, open database that can contain all openly available structured data and documents on all clinical trials threaded together by trial ID. So to explain a little bit more about what this means and also about how we're planning to initially populate this database and also how we're going to present it, I think it makes sense first of all to go through the kinds of data and documents that we're going to be sucking in and matching up together. So first of all, registry entries. Well, actually, let's just do a very quick overview. So we're looking at matching up together, first of all the registry entries on trials and deduping those and spotting discrepancies. Then the places where results are made available, like academic journals, regulatory documents. Then the structured data and documents on methods and results where they've been made available, and we'll go through those in detail later. And then lastly, the kind of free text documents, which in our view should be routinely in the public domain, but often aren't, are often actively withheld, but also there's nowhere for them to go at the moment. So we'll start with registries. The same trial can be registered on lots and lots of different registries, so that is often interesting just simply to reconcile the different registry entries, put them all side by side and spot discrepancies. So for example, we're already aware of cases where a trial is reported as ongoing in one registry and completed in a different registry. So that's interesting because if you were looking in only the registry where it's listed as ongoing, you wouldn't know that the trial had in fact completed, so you wouldn't know that you should be expecting results. There can also be interesting discrepancies on, for example, pre-specified primary and secondary outcomes. There's also another problem, which is that registration is split across lots and lots of different places. So ICTRP, the WHO platform, aims to reconcile some of these, but we're also going to suck in and hopefully match on the individual, for example, industry registries. So each individual company often has a register where it lists its own trials that are ongoing or from the past. So that's registers. Next, academic journal articles. So this is the conventional place where trial reports tend to be made, or at least it's the conventional place where people tend to look for trial reports. Now actually there's a growing amount of evidence to suggest that academic journals paradoxically are not really very good places to report the results of clinical trials. They're often very permissive on people switching primary outcomes. They're permissive on people playing fast and loose with their analytic strategies. And also they tend to be less complete with respect to methodological shortcomings, design flaws, which mean that a trial is not necessarily such a fair test of which intervention is best, and also less complete with respect to reporting in particular adverse outcomes. Now that's partly in fairness because adverse outcomes that are important, that are recognised to be important once a drug's been around and used for a long time by a larger number of people, may not have been recognised as important or salient very early on, and space is limited in an academic journal article. But in any case, we're going to aim to identify the academic journals associated with the registry entries first up, and that means doing, first of all, searches for example, clinical trial ID numbers, but also using probabilistic record linkage techniques. So that means searching on various different fields like study size, principal investigators, titles, drugs, and so on. Now that's a big and interesting challenge. The linkage between registry entries and academic journal articles is probably one of the more challenging for the kinds of linkage that we'll be doing, but I think later on you'll see that there are other forms of linkage where probabilistic record linkage will be more straightforward. So probabilistic record linkage, for those who don't know, is a technique which is very widely used for matching patient data. So is Eddie Fitzgerald the same as Edmund Fitzgerald at 8 Acacia Avenue or 8 Acacia AVE? And there are lots and lots of kind of basic strategies that are used around that, and it's a good way of doing fuzzy matching on data sets. So next, can we do better? Well, Regulatory documents are a really important source of information on clinical trials, and they're very, very underused at the moment, and that's partly because they're very difficult to access, very difficult to track down. So if you want more information on that, it's in the first chapter of Bad Pharma. If you want a really long howl about the state of reporting of clinical trials, there's also references in the Open Trials paper, which you can find on this site. So what you tend to find is, for example, the Drugs at FDA website has these huge bundles of regulatory documents on a particular indication for a particular treatment. They generally don't have a contents page. They're just a bunch of documents, pictures of the sheet of A4 that they've got in their filing cabinet, all pertaining to that particular use of that particular treatment, sometimes upside down. Certainly not the kind of thing where you can do Control F and find a particular bit that you're looking for, but also without a contents page or even a title page, you have to kind of infer which indication they're even talking about. So these are very unnavigable, poorly indexed documents. We're aiming to take the whole bunch, throw them up into a nice place where we can store it, maybe using Document Cloud or perhaps similar code, and then OCR them, index them, and do things like search for clinical trial ID numbers in them. And then we can say, well, it's quite likely that the page before and the page after, at least as a starting point, either side of that clinical trial ID number is likely to pertain to this pre-registered trial. So we can do similar things for the EPAR documents. So EPAR documents, again, a very unknown source of information on clinical trials. When a drug is approved by the European Medicines Agency, they put up a document that contains a summary of various different bits and bobs of data and evidence, including paragraph 2, 3 long descriptions of clinical trials that they regard as kind of pivotal to their decision around marketing authorization. So we will make those kinds of regulatory documents more accessible. There's also another category of regulatory documents which are very, very much underused and have only really come to be recognized as important over the course of the last 5 years, I guess, and those are clinical study reports. So clinical study reports are very, very long documents that are produced for industry trials. They're very stereotyped. They're produced according to a very clearly set out template from the International Conference on Harmonisation of Good Clinical Practice in the mid-1990s, and they can be thousands of pages long. Now, these really tell you where the bodies are buried methodologically speaking. They give you an enormous amount of detail about how the study was conducted, and also about all of the adverse events, about all of the outcomes, all kinds of really rich and important information. So this is the type of document that became particularly salient in the arguments over transparency, for example, of Tamiflu, but also ondansetron, sorry, not ondansetron. So various weight loss drugs were the kind of the big pivotal battle with the EMA to open the floodgates to getting access to these. Anyway, clinical study reports are now more widely available. The EMA, to an extent, makes them open. You can read various things that I've written and others on the back and forth and the one step forward, two steps backwards with their transparency policy, but nonetheless, they are more readily available. And also various companies like, for example, GSK are making their own clinical study reports available unilaterally. Now, at present, these aren't indexed, so if anybody has clinical study reports, if they're posting them in public, we can link out to them. If they have them and they want to upload them to us, then we will find a way of taking it and storing it. Next, structured data and structured data on the methods and results of clinical trials. So, when you make a Cochrane review and you've got the forest plot and all of that, what you're doing is you are manually extracting structured data from the free text of a trial report. So that is an important piece of work which you do to produce your systematic review, but almost as kind of data exhaust, it produces an awful lot of really useful and important structured data. For example, on the effect size, on the number of participants in each arm of your study. Also, people do they manually score the risk of bias for a trial, so the design flaws on various different domains. So typically a trial that is included, for example, in a Cochrane systematic review will have its risk of bias from poor allocation concealment, poor methods of randomization, poor methods of blinding, outcome reporting bias, and so on, graded by an expert reviewer. Now at present this information tends to get lost out in the ether, buried in individual XML files, lost like tears in rain. But this is really useful and important information, and if we can capture it and match it and link it onto the thread for that clinical trial, then it's a kind of basic fundamental rule of open data and data in general that the more information you put together in one place, the more powerful it becomes. These things are combinatorially explosive, and when we come to look at the windows onto the data that we're providing, then hopefully you will be able to see what I mean. And then lastly, oh, just to be clear, so there are already some existing pooled databases of structured data that's been manually extracted in the course of making systematic reviews, including SRDR run by AHRQ. So next, trial paperwork. This, sorry, I've got a cold. This I think is really interesting and important. So there are all kinds of bits of documentation that are involved in conducting a clinical trial which generally remain hidden from view. Now, in some cases this can be really important. So just to give you an example, recently we've just submitted a paper where we found a few trials, rheumatoid arthritis trials, where the intervention group were getting a new whiz-bang rheumatoid arthritis treatment and the control group got a dummy placebo treatment, where in our view and also the view of others, the people in the control group were getting a treatment that was less than the normal standard of care. Now that raises some interesting concerns around informed consent, around equipoise, but in particular we were interested from kind of transparency perspective to go, well, can we get the documents? Can we get the documents from the ethics committees to see what kind of discussions they had around what we think was probably under treatment of the control group, but also what did they say to patients? Did they say to patients, well, if you participate in this trial, it may well be that there are very altruistic patients around, and you say to them, you can participate in this trial, that would be really useful, but you will get less, you've got a 50% chance of getting less than the usual standard of care. So we wanted to see the consent forms, we wanted to see the patient information sheets. We applied for them and we came across various different barriers. Hopefully you'll be able to read that paper if it gets accepted for publication in the next month or two. Now, we all think that this information should be routinely in the public domain. Traditionally, you could argue there just hasn't been a place for it, and I think that's part of what's useful and powerful about the Open Trials project is it's just creating a good functioning empty database for all structured data and documents on clinical trials with a sensible ontology, a sensible data schema, to use a less annoying word, a sensible structure, and then providing various different sensible ways to populate it, which include crowdsourcing, record linkage, straight scraping, and others, data donations in particular. So patient information sheets, consent forms, that's the kind of thing we'd be interested in having and hosting, and that's the sort of thing we're going to make boxes for each trial. And then also things like case report forms. So case report forms are the paperwork, or more likely online obviously now, computerized, but they are the record sheets for the trial. And sometimes actually there are methodological shortcomings in a trial, design flaws, which can only really be identified by looking at the original case report forms. So an example of that, I guess, is, well, you know, boring to use Tamiflu again, but just because it's on everybody's mind at the moment. The case report forms for Tamiflu were the first time that people saw that the diagnostic criteria for pneumonia in some of the trials wasn't a chest x-ray, sputum sample, physician examination features, blood test or whatever, any of the usual stuff you might expect for determining caseness, have you got pneumonia or not. It was, in fact, patient self-report. Now, like a lot of people, I mean, right now I've got a cold, but I'm telling everybody I've got the flu. People, you know, you don't make a diagnosis of pneumonia really on the basis of patient self-report. That's not okay. Or at least if it is okay, we need to know that that's how you did it, and it needs to be like fully front and center, or at least accessible. So that's an example of the importance of having case report forms. Protocols, everybody knows protocols should be available, so that's a really detailed description of how you're running the trial, done ideally before the trial begins, and with certainly any well, you have to do the protocol before the trial begins, but it's hopefully available before the trial begins, and if not, at least with a change log to show you what's been changed over time. not only are we aiming to host protocols, but we're also keen to work on kind of escrow methods so that we can take a protocol which somebody wants to retain as secret until the trial is ongoing or completed, but put a time lock on that so that it's time stamped. So statistical analysis plan similarly, but also lay summaries are the kind of paperwork that you get around trials which are really important and really underused. So we'll talk about those in a little bit more detail in a minute. But so at the moment, for example, every trial that gets approved in the UK, you have to have a lay summary, so that's a description a few hundred words long of what the trial's about, and that has to be done for the ethics committee approval, but typically that just kind of gets lost. It's left in the Health Research Authority's databases, but actually that's the sort of information which, if we can grab it and we can match it using clinical trial ID number or other probabilistic record linkage techniques if need be onto the registry entry, so then when we're presenting information to patients about ongoing trials, we can say, well, here's the technical stuff that we know about from the registries, and this is quite helpful actually if people are hoping to participate in trials. You can give them a search window. I've got diabetes, I live in NW10 and I want to participate in a trial. What is there? But also we can show you not just the tech documents but also the lay summaries, because we've grabbed it, we scraped it, we've matched it. So how do we do all this? How do we match them on? Well, possibly the best way of describing that is by going to a specific example. So let's go here. Okay, so the various different windows onto the data. I'll show you first up the page that we're making for researchers. So this is how we're thinking about presenting the information to researchers up front. So here we go. Up at the top, some kind of basic stuff on title, in this case taken from registry entry, and then an overview. So what are the interventions? What's the timing of the trial? Number of participants? Again, taken from registry entries, sorry, cold. And then, so let's have a look. Things in green are things that we would that we've got. Things in red are things that we would like. And you can see next to the things in red, there's a little upload arrow, and that means we haven't got it, but we'd like it. And if you've got it, give it to us. So registry entries, we've got two different registry entries on this. We've got the industry one and we've got the publicly accessible one. We'll make a presentation to put those side by side, but then also if you're aware of another registry entry, so I'm wiggling my cursor around if you can see there, hopefully. So if you've got another registry entry, click there and give us the link and we'll bolt it on. Next, we'd like to see some papers associated with it. So we found what we think is a protocol. So there are all kinds of good things you can do there. You can search for a clinical trial ID number or other things, but then you can also filter by trial type, and there are various quite good, quite well validated filters for identifying paper type, sorry, not trial type, that we can distinguish reasonably well between a protocol and a results paper. So we think we've got a protocol, but we haven't got a results paper, but we'd like it. If you've got it, upload it to us. Next, regulatory documents. So we think we found an EPAR segment by harvesting all of the EPAR documents that we can find. Will the EMA be friendly? Who knows? And that's actually a really interesting and important part of this project is I'm a big believer in open data, and that means not just that things are available at all, but also that they're available in sensible structured formats where they can be matched, merged, processed, reused and put to greater good. And one of the things that's been really interesting about getting going on this project has been just the very act of asking people for just a bulk dump of their database, which is publicly accessible one way or another. It sometimes presents interesting challenges for people. So, for example, the Health Research Authority has got a reasonably good database of information about trials which they have approved. So they run the ethics committees for the UK. But we want the whole database to kind of bolt it on. And we don't want to cost them any more. Don't know what that was. We don't want to cost them any more money. We can take it in any old format. But just when you ask people for this information, they said, God, you know, that's really interesting. Nobody's ever asked us for that before. Similarly with industry registry, some of them are dire from a structural perspective. It's just a bunch of PDFs that are quite hard to use. Some of them are really good, sensible, structured data. And when you ask people to share that as structured data, they say, wow, you know, what are you going to do with it? And they're quite interested. I mean, I'm sort of surprised at the extent to which I'm not moving enough to keep the lights on. I'm kind of surprised at the extent to which people haven't tried to match and merge and link these data sets up together, but I think there are really important things that can be done when you do that, and hopefully we'll have a chance to get onto that. I've already been talking for about twice as long as I meant to, and I've got a meeting in 42 minutes, but hopefully we'll be done by then. So, regulatory documents. So here we found a bit of an EPAR, which is the regulatory document produced by the EMA when something is approved, and we can show you that. We'll show you the bit where the trial ID appears, the page before, the page after, if you click on there. But if you want, you can also link to the whole thing, and then you can go and see if there's anything more before or after. Other regulatory documents, well, we don't have a CSR, but we would like one. So if you've got one, you can give us a link to it, or upload the file. So once we get into that, there's all kinds of interesting challenges and questions around IP, copyright, fair use, and so on. We will cross these multiple bridges in whatever vehicle seemed most useful at the time. So next, structured data. So we've got some structured data on results from clinicaltrials.gov, which are available for an absolutely teeny tiny number of trials, but they're often more complete and probably more accurate than the reports of trials in free text in academic journals quite often, because in an academic journal you can play fast and loose with switching your primary outcomes and so on, and academic journals actually aren't very good at policing that, despite what peer review and editing is supposed to do, despite the persecution they put you through when you submit your paper. Also, there's just one box on clinicaltrials.gov that's labelled with the pre-specified primary outcome, and you just have to put the number in there. There's not really much room for switching or editorialising. And then we've also, for this one, got some structured data that has been extracted manually by somebody doing a systematic review, which they have had the kindness of heart to upload to SRDR, which is the systematic review data repository run by AHRQ. So next, paperwork. So we've got a blank consent form, and perhaps a patient uploaded that. So we're going to have all kinds of things around. Here's a flag. If you think it's the wrong one, you can let us know. So all the kind of usual stuff around crowdsourcing things. Patient information sheet. So if you've got one, give it to us. We'd like it. Blank case report form. Similarly, we think we've got a protocol because we've got that paper, and we think we've got a lay summary, which we scraped from HRA, and so on. Now, what was I going to say? Can't remember. Let's move on. Next, so further down the page, methodological rigor. Now, let's say the methodological rigor, the design quality of this trial has already been assessed by somebody doing a systematic review. Then that is a variable name and the variable value stored somewhere in somebody's XML file or CSV file, perhaps on their hard drive, or if they've shared it to SRDR there. We can take it, match it on, and we can convert it into free text and make that come alive, make it useful to people. So, for example, we can say on this trial, look, the methodological rigor of this trial, which you might have wanted to read to critically appraise yourself, it's actually already been scored in a systematic review in September 2012, where it was scored at being at high risk of bias from allocation concealment, unclear for method of randomization, and unclear for risk of bias from poor blinding. So here's a link to the systematic review where it was scored. Read more about what this means and so on. Next, individual patient data. So we are not in the business of hosting individual patient data, but we're very glad that other people are. More to say on that another time perhaps. So we can also infer, firstly, whether or not individual patient data is available for a trial on application, because we know who sponsored it, what year it was done in, and we know what that organisation's rules are about sharing IPD. We can also walk you through the process of applying. So we can point you to where it is, we can point you to the application process, we can also track applications if we know about them, so we can say, well, we know that people have applied for this and what was the outcome perhaps. Now, we can also identify if IPD repositories, individual patient data. So the individual patient data, for those who don't know, and everybody who's still watching this incredibly boring and detailed description by now will definitely know, right? You'd have fallen by the wayside of detail. But individual patient data is absolutely like what happened to each individual patient in the trial. It's not like summary results. Summary results you can definitely share on the internet. There's no risk of re-identification of individuals. There is a modest risk of re-identification even in pseudonymized data that is about individual patients, and so you can't just bung it online. You have to have various different access controls around that. So that's why we're not funded to run that kind of information library, because that requires a lot of manual labour and access controls that is not our thing. But if the people who are doing that, for example, clinical study data request, present a sensible public-facing surface, an API ideally, but if they just have a list even of the ideally trial ID numbers whose IPD they are hosting, then we will be able to say for definite this trial has got its IPD stored over there. CSDR is actually based in that corner of the office here. So next, help us improve this data. So this is the kind of important thing around crowdsourcing. My colleague Jonathan Gray from the Open Knowledge Foundation sort of writes these beautiful dewy-eyed things. I'm totally on board with them. Where he sort of talks about participatory data infrastructures. It's beautiful prose and it makes you weep. I can't replicate it, but read the section of the paper about participatory data infrastructures. So help us improve this data. Dedupe. We think there are 2 more registry entries that might match this one, so review them. That reminds me of what I was going to say earlier about documents. We'll go back to that in a second. Give us results. So the last fuzzy match search for results for this trial was 2 days ago. The last manual search for this trial was 92 days ago by Open Trials librarians. So what does that mean? Well, we've got a tiny bit of funding. So our funding is basically to produce a sensible data schema and a sensible underlying database with a sensible data structure. That is no small thing. Produce some sensible windows onto it, like this researcher view and also a patient view and some summary statistics, which we'll come on to in a moment. But also, we have a tiny bit of funding set aside for manually populating the database ourselves. So, you know, health librarians, if you've never worked with them, they are absolutely amazing. You know, you say, oh, I'm looking for all of these trials, and they'll send you their search strategy, and they just do it in an amazing, perfect way. Now, we don't know how we're going to spend that. It may be that we get data donations, we must talk about those in a moment, which bring a particular field or class of drugs or drug up to a reasonably comprehensive population of the data fields that we're interested in which case we'll spend our information librarian time on perfecting that. It may be that it makes more sense to identify a patient group who are really motivated. So there are some medical problems which afflict people who include more younger, dorkier people. So I don't want to exacerbate health inequalities, but right now we're just trying to get the thing going. So maybe if there's a really active nerdy patient group who want to work themselves towards populating the database as completely as possible, then we can put our manual librarians on to modifying that. Anyway, we've got lots of really interesting ideas around how to track manual searches and search strategies, and also track your search strategy and then rerun it. So one thing that we could do, for example, is we could put a window onto PubMed through Open Trials. So you could say, I'm looking for this trial now, and we can track your search strategies and the returns that you got. And then if you say, well, I've tried and I couldn't find anything, then we can also store your search strategy. And if somebody comes back 3 months later or 10 months later and says, oh, I can see somebody's already looked for this trial, you could say, well, I'm going to look at what their search strategy was, what their search terms were, and if they look broadly sensible to me, then just show me all of the new results that have come in since they ran that, and I will screen those myself. So that's probably, I mean, that's sort of overambitious, but that's the kind of thoughts that we're having around how to just kind of clean up and impose some coherent order on the current very kind of dispersed mess of activity around trials and data, which is really wasteful. So next, tell us about unregistered trials. Upload any trial information you have on studies we don't know about, consent form, an academic paper. Now that's really important. Firstly, obviously it goes without saying, there are going to be an absolute ton of trials. I mean, the majority of trials, see my forthcoming paper on this, predate the era of registration. Now, of course, we are threading together all the data and documents we can get on those. So we'll be grabbing those with various obvious search strategies, but also if you know about any new trials that we don't know about, you can give us that paper. But we've been talking to a lot of people, so we've run a couple of user engagement workshops already on this, which have been really exciting, really fun. People have come up with amazing, great ideas and ideas of new data sources that we hadn't thought of, and also donated data in a way that we'll talk about in a moment, because that is a kind of final, really crucial way of populating the database. But also, everybody comes up with their own interesting use case, and that's one of the sort of important things about open data and transparency, about going beyond just like making documents available at all, but making them available in coherent ways where they can come alive and be used. You know, the street will find its use for technology, as William Gibson said. So when we spoke to people who work in developing countries, they said, God, this is actually really useful and interesting, because people sometimes come to us and they say, oh, my grandmother, she's been put in this trial. And clinicians might say, well, I didn't know there was a trial on blood pressure drugs happening in this region. Have you got any paperwork on it? And they'll kind of pull out a patient information sheet or a consent form. Now, I hope to make an app, but also people just send us a picture. Just take a picture of the consent form on your phone, send it to us, and then we can put it in our queue of as yet unreconciled documents about ongoing clinical trials, and act as an observatory for potentially unregistered trials happening in countries where the regulatory framework is perhaps less coherent and complete than it is in developed countries. So that, I think, is quite big potatoes. Related to that, next up in this little list of help us improve the data, work on the queue. So there are 836 documents currently waiting to be reviewed that could be attached onto an existing trial in the database. Now, next, let's look at the right-hand column down here. So here's a few bits and bobs on conducted in. Those little stars, by the way, are transparency scores. We'll talk in a moment about our ability to make overall summary statistics and metrics for any part of the database that is reasonably well populated. But next, credits and acknowledgement for the data on this page. Now this is really, really important, and it's a real challenge around microcredits, and everybody knows there are huge problems with the incentive structures of academia generally, right? You don't get as much credit as you could for useful, valuable, small data contributions, for sharing your data from your study as open data, and so on. So we're giving really full credit. So first of all, to anybody who helps upload information on the page. So the protocol was matched by Caroline Smith from UCSF. So the EPAR segment was uploaded by Martin Durden from Imperial College London, so that somebody came to the site and said, hey, actually, you know, this bit of this EPAR relates to this trial. But also, more interesting, protocol matched by Caroline Smith, UCSF, from her dataset in this paper. Now, the third strategy for populating the database, alongside straight matching on ID numbers, and actually, you can get a very long way, by the way, by having lookup tables between different data sets. So you just need one lookup table that matches public registry clinical trial ID against industry internal clinical trial ID, and that might be the zipper that helps you bring together two big groups of documents that were previously separate. The power of record linkage is really not to be underestimated, but especially when you're gathering lots of data from lots and lots of different places. We will see, right? This is no small undertaking. But alongside that and people uploading stuff, there is also data donations. So what does that mean? Well, for example, big and small, if you've done a publication bias study, then you have taken a list of trials that you know have happened. So that might be from a registry, or it might be from the trials approved by an ethics committee. And then you've got a date on which you searched for the results of those trials, probably on PubMed. And then you've either got a link to the paper, if you found one that reported the results, or you've got a confident, no, the results of this trial were not published at this date. Now, with that, you produce your summary statistics for your published academic paper on the proportion of trials that are unreported at 2 years follow-up or 4 years follow-up or whatever. So you go, 37% were missing or 58% were missing, and then you get on with your life. And meanwhile, that data set kind of sits unused in your laptop. But this is actually really important information that we can use, because it is a manual match between a registry entry and a published paper, or a confident no. Now, really interesting again with the whole kind of open data thing, just seeing what happens once you start asking people for structured data. So a couple of people who've come to our user engagement workshops, who've done these kind of publication bias cohort studies, just immediately go, oh wow, this project, it killed me for a year. It was the most boring thing I've ever done, but I got this really good paper out of it. If you can make any good at all of this data set with 700 rows in it of matching a trial and ID against a publication, then for God's sake, have it immediately. Thank you for making it all that work less pointless. Some people say, no, why should I? I mean, that's a general principle of this whole project. You haven't lived until you've invited transparency advocates to be transparent with their own data sometimes. But at the same time, I'm completely alive to the anxieties that people have. So firstly, we definitely don't want anyone's data that they're about to make another paper out of, right? Everybody who spends time producing a data set, basic rule of open data and data sharing in science, has the absolute full right to exploit it. But also, this is really valuable information that may have uses that go beyond your own personal interests in that. But a really important part of that is credit. So that's what we do. So this protocol was matched onto the rest of the data set by one particular person who'd produced that linkage as part of the underlying data for a particular analysis. So we give credit. We give credit firstly here on the page, but also we'll give credit whenever people do bulk downloads. So we're going to be delivering bulk downloads, and that's one of the most important parts of it. And wherever the licenses that we've got stuff under, so we won't talk about that. I mean, hopefully everybody's just happy to share and do things as proper open data. But where licenses permit, people will be able to download the data. When you download the data, you also get a big pop-up, and it says the correct way to cite this data is as follows. You cite the Open Trials projects, that's where you got it from, that's where it was aggregated, and that's work that was done. But also you cite, you put these names of individuals into the acknowledgement section of your paper. That's really important, so that their work is recognised. And also all of the following papers contributed their underlying data to improving the structured data that we have, and so you have to cite those. So people who donate data don't just get recognition, they also get citations, which are the current ludicrous currency of academic work, and so be it. Funders struggle to develop better insight around that despite everything they say. So next, all right, so I mentioned if you've got reasonably complete data in a particular field, then you can start saying, all right, what proportion of all of the trials have reported? Now that does require a good comprehensive population, but nonetheless it's something you can do. So this is mock-up, which is why they're all greyed out. You can get reasonably complete data for certain fields, but anyway, we'll talk about that another time perhaps. So you can say, all right, the 5 biggest sponsors by number of trials sponsored, what's their overall score, what's their overall ranking, the 5 biggest treatments by volume of prescriptions, you might say is a good sort of ranker, the 5 best interventions for transparency, or perhaps the 5 worst. So there's a paper by me in PLOS Medicine 2014 on the value of these kinds of performance metrics to try and drive up behaviour, and there are also various other people doing work on this, which I hope is going to get published soon, and when it does I will shout about it from the rooftops because I think it's really important and great. So we really need to get on with our lives. So this is like a slide from our user engagement workshops, but we're just building now. So we ran a bunch of user engagement workshops because we wanted criticisms and feature requests before we built, rather than after we'd like spend all the money on coding and run out of runway. So here are our questions. Get in touch very soon. I'm going to show you all of how to get in touch with us and all the different ways of working with us in a moment. So firstly, are there any other features that you'd like us to implement on the service? Are there any particular problems that you'd like us to solve? So any particular uses you have of trial information, or uses you'd like to make of trial information that you think we can help on? So get in touch and tell us, and we can see if we can kind of bake some of that into the design of the system. Oh god, we haven't talked about any of the patient facing stuff. Okay, we'll come to that in a moment. This was supposed to be a 10-minute video. Next, how would you improve the example pages that I've just shown you there about how to present this information? So the one for researchers I think is fairly well thought through. The reason I didn't do the patient one is that it's currently not in as good a state, and that's partly because it's just another big extra bolt-on module of work. So we're totally keen to have collaborators, anybody who wants to get involved in kind of leading or collaborating on any of that kind of stuff. Next, are there any more data sources we should include? And by that I mean any more types of data, or any more types of documents that you think should be bolted on. So people keep coming up with really useful ones in our user engagement workshops. So don't worry if you think it's too obvious. Just get in touch, let us know. opentrials@okfn.org, email address at the end of the page, at the end of the talk, and also probably on the website opentrials.net, which you are almost certainly watching this on. Next, have you got any data on trials that you'd like us to host and make more discoverable? So you know, if you do systematic reviews, you've got a ton of structured data that's been manually extracted. If you are systematic reviews automation dork, and I use the phrase dork as a term of endearment because I am a dork, then you may have manually extracted stuff which you're pretty confident on that you'd like to share out to us, and then we will reciprocate in spades. So next, just to kind of expand on some of those a little bit, this is from the pages of opentrials.net, different ways of working with us if you'd like to, and I really hope that you will want to. You know, it feels funny talking at such length about something alone in your room at your computer. Anyway, firstly, data partners. You know, I used to think that sort of thing was cheesy, but I have to say this is a really big collaboration of a lot of people, and I think the phrase stands up. So data partners, people who've got data about trials. So if you've done a study on publication bias like I described, then throw us the CSV. We will shower you with credit and glory, and we will use it to improve the data. Have you done a systematic review, as I said? Then share your structured data to SRDR or to us. Have you mapped one dictionary of medical terms against another that will allow us to, again, automate cleaning up and reconciling the data? Really important, and just another illustration of how the information architecture of evidence-based medicine is a flawed ad hoc ecosystem of legacy projects, many of which come practically in the 19th century. Next, funding partners. So look, this is infrastructure, right? Infrastructure is next to impossible to fund. We have phase 1 funding to produce a sensible data structure, use the best low-cost methods we possibly can to populate it, and produce some sensible windows onto it, and workshop those and get those to the best standard that we can. But we need more, realistically. People are really reluctant to fund infrastructure, and that's why these kinds of projects don't already exist. So we don't want to run this on blue tack and string. Ideally, we want to make it as good as it possibly can be, and we have good governance. We are serious people. So check out our advisory board, who it's a galaxy of bigwigs by whom I am humbled, and get in touch. Next, and also any kind of in-kind resources that you think will help us to widen the scope and the ambition and get things done. This whole thing should have existed 10, 20, 30 years ago. It is insane that nobody can tell you how many trials have been done. Nobody can tell you how many trials are running in England right now or in Wisconsin right now. Wisconsin may be a bit better. Anyway, next, community partners. So if you're interested in open data and health, then get in touch, because I'm sure you've got good ideas that we would like to discuss with you. Can you contribute your knowledge and your needs and your network to us? So, you know, use cases, but also people who might have ideas and resources. Next, oh, and also actually, just so, I mean, really hugely crucially, if you you know, if you've got migraine and you're interested in evidence-based medicine and you want migraine treatments to improve, then cleaning the data on what we already know about migraine treatments and helping us get to the point where we can say confidently, well, look, you know, only 70% of the patients' data from the trials that have been done on this migraine treatment have actually been published, then that's really important, useful stuff, and we would really like you to work with us. You know, if you've got a health problem and you want to see the trial data improved and you're a nerd, then please get in touch. And this is news you can use, right? So then once you've done that, then your patient group can then write to the companies or the principal investigators or the institutions of studies which are currently completed but withheld more than 12 months after completion, and say, hey, please can we have the result? You know, I take this drug, or I have this disease, our members have this disease, please can you tell us why you haven't published this results and when you're planning to publish them. Next, individuals. So if you want to contribute time as a volunteer, work with us, if you think you've got autonomous funding that will allow to cover your time on this project, or if you think you would like to get some to do some other kind of bolt-on modules, oh my goodness, even in an hour I haven't been able to cover everything, but there's lots and lots of extra bits and bobs that can be bolted on, and if you're clueful and you know about this stuff already, then you will have you'll know what I mean, and you'll have your own thoughts, in particular around the kind of record linkage challenges and stuff like that. I think there's absolutely huge amounts of room for taking kind of existing little algorithms and projects, little giant algorithms and projects around extracting structured data from free text and perhaps using those, and we can give you training data in return, but also pool automatically extracted data and so on. Yep, all of that. And next, users. So we really want people who want to be kind of early users, testing out the beta versions, giving us feedback, feature requests, and all of the rest. So the patient-facing view onto the site, just to be clear. So firstly, there's a huge amount of stuff that can be done there. Firstly, around well, you can do sort of search, like I'm in this postcode and I want to participate in this trial, as we discussed earlier, but there's also lots of stuff you can do with better record linkage and also having a participatory data infrastructure, and don't hate me for using that phrase. For example, as I said, we can suck in better quality lay summaries, but also if somebody wants to write a better lay summary on a trial in progress or a trial that already exists, then they can, and they can give it to us, and we can post it and share it with the world. And by the way, we don't want to own any of this stuff, so you know, the code and the data all out there, open licenses and so on. So we've already got a prospective partnership lined up with one of the science writing masters, and if you run one, then please get in touch, where people can write a lay summary as a kind of project, and then share it to us, and we will host it to the world. Ian Chalmers and others have been talking forever about the notion of having a good trials guide for patients. Well, actually, you know, if you're an MSc clinical trials student, then you do endless critical appraisals of ongoing trials. You think a lot about the strengths and weaknesses of the design of a trial, and you could write a public-facing review of an ongoing trial. You know, so instead of people being kind of left in the dark, you could have, well, you want to track contributions and know who people are. So you know, I'm a professor of evidence-based medicine, or I've got a PhD in blah blah blah. Here's my review of this trial. It's a really important question because we don't know which of these two treatments for this disease is best. It's a sensible study design, but unfortunately the inclusion and exclusion criteria mean that it's being conducted in ideal perfect patients rather than the kind of typical patients, so it may have it may not produce results that will be generalizable, necessarily applicable to everyday patients. And also, unfortunately, the outcome measure is not a real-world outcome measure that matters to patients like pain, disability or death. It's a blood test, and this is likely to be because of cost saving, but nonetheless that's something to bear in mind when making your decision about participating in the trial. And I think having that kind of live good trials guide for patients, I think, has enormous potential, but it also throws up all kinds of really interesting challenges on which I could talk from now to the end of the earth, but my next meeting is in 13 minutes, so I really am going to go. So that is the Open Trials database, and I hope you find it interesting. I hope you feel enthused, that you think that there might be stuff in it for you, that you would like to work with us and help everyone get better data, and most importantly, this is how to get in touch. So come to opentrials.net, sign up to our mailing list if you want to hear more. You can email us, opentrials@okfn.org. If I've got that wrong, then this will now be an editing glitch in the video, which somebody else will inflict upon it. Follow us at Open Trials on Twitter. And thanks to Laura and John Arnold Foundation, who've given us phase 1 funding very generously and very insightfully. They are like the Medicis of transparency and better data in science. Rufus Pollock, Open Knowledge Foundation, Emma Beer the same, Jonathan Gray and Sam Smith the same, Anna Powell-Smith and Louise Crowe, who helped with earlier versions of this, and many more. Thank you very much for watching, and please do get in touch with the